Hey, welcome back to Dr. T's Wellness Emporium. I'm Dr. Brendan Troster, PhD in developmental psychology and licensed therapist. So today's video is a continuation of the last video I did, which was the myth of mental illness, kind of taking a look at the work of Thomas Szasz. Today we're going to take a look at the myth of diagnosis. So you could go ahead and watch that video now if you wanted to. Honestly, though, you will be able to understand everything in this video without having seen that content. So you could watch it after this or now, up to you. But anyway, we're going to dive into that myth of diagnosis. And what we're going to look at is how psychology really traded understanding and context for the medical model. So what do we have now with psychiatry? We've got the checklist for mental illnesses, and then, the labels themselves that go along with those mental illnesses. So we're going to trace the history of that shift. We're going to also look at the idea of why some researchers have said that the psychiatric diagnoses are scientifically meaningless. That's a direct quote. And then we'll also take a look at, you know, what we can do to move beyond these things. Okay, so from the very beginning of modern psychology and psychiatry, there has been this desire and fascination with medicine and being accepted as a legitimate scientific branch of the medical field. And this goes all the way back to the late 1800s with Emil Kraepelin, and he's considered the father of modern psychiatry. And he started classifying mental suffering like they were diseases. So he grouped symptoms into clusters, argued that these patterns represented distinct illnesses. And so this mirrored, how doctors diagnose conditions like tuberculosis, pneumonia, by identifying lesions or biological causes. The doctors identified lesions, biological causes. Of course, that did not happen with psychiatry, but that's what they were trying to do. And then around that same time, we saw the asylums pop up across Europe and America, and they were treating conditions like hysteria, melancholia, and mania as medical problems that needed confinement and medical intervention. But that wasn't the whole picture. So psychoanalysis emerged around the same time and offered a different story. So it was seeing mental suffering as unconscious conflict, life stress, unresolved developmental issues. And so for a long time, we had two visions that kind of coexisted together. There was the medical model, which was looking for the biological disease, and the psychological model, which was looking for meaning and also life context. So psychology wasn't fully medicalized. It was a mix of medicine, philosophy, and inquiry into the human condition, if you will. So after World War II, okay, that's when things started to change. The U.S. had thousands of returning veterans. They were experiencing trauma, anxiety, and depression. And the mental health field needed a standardized way to describe these problems. And so in 1952, the APA, or the American Psychiatric Association, published the first DSM. And so that's the Diagnostic and Statistical Manual of Mental Disorders. So the DSM-1 listed just over 100 disorders. And many of these were described as reactions. For example, depressive reaction or anxiety reaction. And the DSM-II in 1968 expanded the list, but it still kept that psychodynamic framework in it. And so the early DSMs were not fully medical. They still saw distress as a response to life's challenges. And by the 1970s, though, there were some things that happened that caused kind of a crisis in the psychological field. And so the psychologist David Rosenhan in 1973 conducted this now very famous study called Being Sane in Insane Places. And what happened was healthy people got themselves admitted to psychiatric hospitals simply by saying they heard voices. And then once inside, they behaved normally, but the staff continued to treat them as if they were mentally ill, despite the fact that they were showing no continued signs of mental illness. And so what this did was it exposed a big problem in that that the scientific validity of psychiatric diagnoses were not there at all, and they were completely unreliable. So, two psychiatrists might see the same person and give completely different labels. So, what we saw then is by the late 1970s, psychiatry was many in the field were afraid they were going to lose their scientific credibility. So they decided that they needed a more objective, medical sounding diagnostic system. And this is where we got the DSM-III, which was published in 1980. And it overturned the whole thing. It was kind of a revolution in the psychiatry and psychological fields. And that so psychoanalysis and all of the psychoanalytic language that had been in the early DSMs was completely tossed out. And diagnoses then became a checklist of, of observable symptoms. And each disorder had then specific criteria. So, like major depression has at least 5 of 9 symptoms for 2 weeks, some stuff like that. And so, for the first time, mental health diagnoses looked like physical medicine. There was measurable, categorical, and standardized, right? But the problem is that there was still no biological marker for any of this. There was no blood test. There's no brain scan that could prove these disorders existed as diseases. It was literally a group of men sitting in a boardroom, I imagine, somewhere, and they um, just kind of created these disorders and gave it a medical sounding framework and then put it out there as the DSM-III. And I'm not minimizing things. That's literally what happened. A group of men got together, decided what and wasn't a mental illness, and they're continuing to do the same thing today. But so there was, one of the big motivating factors for psychology and psychiatry to embrace this model was money. Okay, insurance companies and government programs, they started requiring a DSM diagnosis before covering therapy. This is just like it is today, right? It was so without a disorder code, there would be no payment. Um, so to get people help, psychologists, psychiatrists, therapists, they had to put a label on people, even if their suffering was situational or relational, and not a disease. So by the mid 1980s, if you wanted therapy, you needed to have a diagnosis. And this really kind of cemented the DSM as the standard, right? That whole medical model thing became the standard. So from that point on in the 80s, there, what we saw is that psychology and psychiatry aligned more and more with medicine. And this wasn't because there was a whole new batch of scientific inquiries and results that proved mental illness was a disease. It was simply because that whole system that had cropped up there, the insurance industry, it required these things. So if we kind of move forward from that to today, that the research shows that there could be some problems with this whole model of diagnosis. So in 2019, at the University of Liverpool, they analyzed the major psychiatric diagnoses and declared them scientifically meaningless. And so here's why. So here are their findings, or why the lead researcher there admitted that they were, scientifically meaningless and couldn't be used for research. So there's symptom overlap. So the same symptoms, like trouble sleeping or fatigue, that can be in multiple disorders. Okay. There's arbitrary thresholds. So why is it 5 of 9 symptoms for depression and not 4? Uh, so this is basically just because the committee decided that that's what it would be. That's really it. That's what happened. And there's no biological validity. So after decades of research, and I mean, we hit on this in the Myth of Mental Illness video, there there have been decades of research and searching, and there is no reliable biomarkers or brain scans that can diagnose mental disorders. Also, context in the DSM is largely ignored. Now, it is mentioned, but it's not it's not part of the diagnosis. You gotta just meet the list of criteria, you get your diagnosis that day. So, like trauma, family dynamics, social stress, and those are often overlooked, and for just the labeling of the symptoms. Um, and so, what we also have is Alan Francis. So he was one of the chair people on the DSM-IV, and he admitted that psychiatry has medicalized normal life. So let's take a look at an example here that I created. So you know, this isn't based on any single individual I've worked with or anything. It's just a little vignette I created. And so it's we'll say the guy is Jason. He's 28 years old. He struggles with focus. He feels tense. He has trouble sleeping. He feels hopeless on some days, and he avoids social events. So now, depending on who Jason goes to, he could be diagnosed with anxiety disorder, ADHD, or major depression. So these are not distinct diseases. They're overlapping descriptions of human distress. So Jason doesn't have like 3 different illnesses, right? Look at his life. He's overwhelmed. He is, feels out of balance, and he's probably stuck in some unhealthy relational patterns. And that's really what's going on with him. But the problem is here, the system demands that there be a label. Now, in order, to treat Jason, like if I were to have to treat Jason in my office, I have to decide which one of these I want to give him. Okay, hey, which diagnosis do you get today? That's required. The insurance companies demand that they have that. Now, if we look at the history of the field, not everyone, well, there were a lot of psychologists, psychiatrists that were not comfortable with this medical model. They did not like it. One of the things that cropped up was family therapy was a reaction against this idea. And so people like Salvador Minuchin, who was the founder of family systems therapy, he argued that you cannot take a person out of their context and understand them. In other words, you can't take someone out of their important interactions with their family, their friends, their social circle, the job that they're at. All of these things are important for understanding a person. And so instead of like asking, like what illness or disease, mental disease, does Jason have, a systemic therapist, which are marriage and family therapists, they really look at how do his relationships, his family structure, his social environments maintain his suffering. What do they do to help support the suffering of the individual? And also, is is what we are seeing here in front of us, are the symptoms that we're seeing, are they actually an adaptive response to a dysfunctional system? And so that's why you see marriage and family therapies focus on boundaries and roles in families. They look at communication patterns, look at cultural and social pressures too. Those are all important contexts to consider when looking at a person. Um, and you don't need a diagnosis to help someone heal. So, like marriage and family therapy or the systemic approach, it sees suffering as relational and contextual. It's not a defective brain that needs a medical label. The model itself anticipates things like trauma informed care and holistic therapy approaches. So, what we're doing instead is we're focusing on meaning, connection, and resilience. So, what happened? Well, to summarize what we've talked about here, the medical model gave psychology and psychiatry a seat at the table of medicine, which they had wanted for a long time. There's a lot of them that felt like this legitimized the whole field, and with the medical model. And in the in doing that, what happened is uh, they basically reduced human suffering to categories that don't map into real diseases. Um, and for anyone out there watching, if you've received a diagnosis, um, and been labeled, remember that your diagnosis is not your identity. Um, it's not proof that like you're broken, your brain is broken. And that also the situations you find yourself in, your family, friends, your important relationships, your job, all of these things are important. In other words, the context you find yourself in is important and needs to be considered. And so with MFT, marriage and family therapy, what we're trying to do is move more towards models that look at the complex nature of human beings, right? So integrating mind, body, spirit, community, all of these things. And really, that's my goal with um, uh, these videos, the content I'm producing, is to try to spread awareness of these things. And if you have found this video valuable, please hit like and subscribe to my channel to get more content like this. And also feel free to share this with somebody else that you think could be interested in this content, or maybe it's somebody who's been told or they feel like they're nothing but their diagnosis. And in our next video, what we're going to look at is the idea of brain scans and how useful are these brain scans. So we hear things like the ADHD brain is different than a normal brain, or the schizophrenic brain is different than a normal brain. Well, we're going to dive into that and ask the important question, is that actually true? Can we actually see anything useful from these brain scans? Thank you for joining me, and I will see you next time.